This video is on liver cirrhosis. Cirrhosis implies irreversible liver damage, and histologically, there is loss of normal hepatic architecture with bridging fibrosis and nodular regeneration in liver cirrhosis. These are the causes of liver cirrhosis, which are chronic alcohol use, chronic hepatitis B or C infection, genetic disorders like hemochromatosis, where there is iron overload, alpha-1 antitrypsin deficiency, and Wilson's disease, where there is copper overload. Hepatic vein events like Budd-Chiari syndrome, non-alcoholic steatohepatitis, autoimmune disease like primary biliary cholangitis, primary sclerosing cholangitis, or autoimmune hepatitis, and also drugs like amiodarone, methyldopa, and methotrexate can cause liver cirrhosis. On physical examination, on general inspection, expect to see a jaundiced patient with yellowish skin. We look at the hands, look for signs of chronic liver disease like finger clubbing, leukonychia, where there is white nails, koilonychia, which is spoon-shaped nails, palmar erythema, flapping tremor, and Dupuytren's contracture, especially if there are chronic alcoholic. On the arms, we look for needle marks to suggest for needle sharing activities causing hepatitis B or C. Loss of axillary hair is a sign of chronic liver disease, and also look for bruises that could suggest for coagulopathy in chronic liver disease. On the face, we can look for parotid enlargement to suggest for chronic alcohol drinker. And on the chest, look for specific signs of liver disease like spider nevi, which I will show a picture later on. And on male patients, we look for gynecomastia, where there is breast enlargement. On the abdomen, we expect to see ascites, where the abdomen is distended. Hepatomegaly in early stage of liver in the early stage of liver disease, where after a certain time, the liver becomes cirrhosed, so it will be shrink. So there will be a shrunken liver. And other signs are splenomegaly and also testicular atrophy, which is a sign of chronic liver disease. So remember that for liver disease, hepatomegaly is in the early stage, whereas in late liver cirrhosis, the liver will be small. So it might not be palpable. These are some of the pictures. The first one is the Dupuytren's contracture. Second is the spider nevi, which is seen in chronic liver disease. And third is a picture of finger clubbing. Liver cirrhosis is only one of the causes of finger clubbing. There are certain diseases that could cause this sign as well. For investigation, we can do full blood count. Expect to see low white cell count and low platelet, which could suggest that there is hypersplenism. Liver function tests, either normal or increase in bilirubin level, and a high AST, ALT, ALP, and GGT. And later on, with loss of the synthetic function of the liver, we have to look for low albumin level. Other tests are done to find the cause of the liver cirrhosis. So we can do hepatitis serology to rule out hepatitis B or C, and do an autoantibody testing, for example, ANA, AMA, SMA, and others, to look for any autoimmune disease that could have caused the liver cirrhosis. Alpha fetoprotein to check for, it is a tumor marker for hepatocellular carcinoma. Liver ultrasound in liver cirrhosis, we expect to see a small liver and also look for some focal liver lesions. If the patient is having ascites, where there is abdomen distension, we can do ascitic tapping for culture and sensitivity. And liver biopsy can be done to confirm the clinical diagnosis in some cases. For management, we divide it into general management and specific management. So for general management, good nutrition is very important, and alcohol abstinence is important as well. we try to avoid NSAIDs, sedatives, and opiates. And if the patient complains of pruritus, where there is itching of the skin due to the deposition of bile salts under the skin, we can give cholestyramine to help relieve the pruritus. And we consider ultrasound and alpha-fetoprotein level every 3 to 6 months to screen for hepatocellular carcinoma. For specific management, if the patient is having ascites, we offer bed rest and fluid restriction, which is less than 1.5 liter per day. Low salt diet as well. We give spironolactone per oral as it counters the deranged RAAS system. We also chart the daily weight and aim for weight loss of around half kg per day. If there is poor response, we can add on furosemide, which is a loop diuretic. If the patient is having spontaneous bacterial peritonitis, this is a condition we have to consider in those patients with ascites who deteriorate suddenly. And some common organisms are E. coli, Klebsiella, and Streptococcus organisms. So the management is to give piperacillin with tazobactam for 5 days, or until the culture and sensitivity results are out, we can give specific antibiotics. For patients who have encephalopathy, we give prophylactic lactulose and rifaximin. The complications of liver cirrhosis are hepatic failure, which could show coagulopathy, encephalopathy, hypoalbuminemia, sepsis, spontaneous bacterial peritonitis, like I mentioned just now, and also hypoglycemia. And another important complication is portal hypertension. And some of the signs to suggest for portal hypertension are ascites as well, splenomegaly, portal systemic shunt causing esophageal varices, and caput medusa, where there is enlarged superficial periumbilical veins. These are the signs of portal hypertension. So the only definitive treatment for cirrhosis is liver transplantation. This increases the 5-year survival from around 20% in end-stage disease to around 70%. However, there are some contraindications for liver transplant, which includes if the patient has extrahepatic malignancy, which means cancer in other places, severe cardiorespiratory disease, systemic sepsis, expect them to be non-compliant with the drug therapy, and also if they are still ongoingly taking alcohol. That's all for this video. Thank you.